Welcome, Thriving in Chaos, episode number 1. We are super excited to be here. I am your co-host, Dr. Stephen Diane. I'm with the lovely
Hi,
Dr.
everyone.
Sabrina Fabi. And for the next couple hours, we are going to introduce you to a new way in education. This is going to be top quality education, but also fun to watch. And that is something unique and new, and it's something we are so ready for. And that is one of the benefits of COVID, something we've learned in this time period. So first, we're going to do, right after this, you're going to see a presentation by Dr. Fabi. And your presentation is going to include?
I'm going to be covering biostimulation. So all the evidence that is out there right now to support basically the role of biostimulation in thickening up our dermis, as well as promoting elastin fiber formation to really make that skin recoil back, and so we can get tightening, not just from injectable biostimulators, but also from energy-based devices.
And I can attest to the fact that she has spent hours and hours and hours writing this. It is one of the best presentations I've ever seen. And you have got to watch it if you want to know all the science. It is top quality. This is like high energy, really good stuff. And then after that, we're going to do a Q&A, about a 10-minute Q&A. And then we're going to go through me walking through the office. I'm going to show you all the things we've done in this post-COVID environment, because the world has changed. And from walking into my office to getting a treatment to walking out for me, my patients, my staff, I'm going to go through exactly the specific details and how we're managing that now. And then after that,
from there, we'll come right back. So I'm going to be doing a treatment on a patient live. And so the benefit of doing this when we put this together is that we really wanted to bring you into our offices, which is a unique experience. You usually see us on stage or perhaps in a conference room, but the difference here is that you're actually coming into our offices so that you can really see how COVID has affected us. And we can take you, from the reception area into the treatment room and really walk you through the patient experience, and then be in the treatment room with me and the patient, where you're going to see me do live injectable biostimulators, as well as microfocus ultrasound to be able to tighten and lift the skin of the chest, inner arms, as well as the buttock.
And really important is to understand how to do this in a post-COVID environment. The world has changed, as I said before, and every single day we're coming up with new ways that are easier and better and more efficient to treat the patients. And of course, we have to be sensitive to both the patient safety, our safety, and the staff safety. So I want to make sure that we show you what we're doing, and maybe you have ideas that work better than ours. I'm happy to hear about it. Please tell me about it. And I expect this to be one of the best educational experiences you've ever had. If it's not, I want to hear about it.
Yeah, remember, you have a question and answer little box at the bottom of your screen. We want you to engage. The point of this is that it is more informal. We're doing this with our own camera and a white backdrop. And so we want you to really engage with us. That's the point. We're not in some sterile auditorium with 2,000 or 3,000 people. So make sure to use that question and answer little box that you have on your screen. And we're going to be taking and fielding those questions throughout the program.
And one more thing I want to mention is that after we're all done with this, the two of us are going to be together on Instagram Live. So any questions that come up that you haven't been able to ask us during this presentation, please come to us on Instagram Live, and we'll be happy to talk to you about that. That's going to be on Sabrina Fabi on your
my Instagram handle, Sabrina.Fabi. Super excited.
All questions are welcome. Okay, so let's get started with the next part.
So with that, we're going to take you on to the basic science of biostimulation so that you know all of the literature that is out there to support what you're doing in clinical practice and to support what I'm going to be demonstrating today to you on our patient. And so the librarian me is going to be going through all the evidence to
the nerd
is going to be coming out. That's my character on the Jets.
Yes.
But essentially it's going to be coming out.
Just on the Jets.
So yes, I'm a nerd at heart. And so I'll go through all the evidence to support the claims that we're going to be offering today that's in the literature. And then we'll see you in about half an hour.
Okay, and thank you to Avenue and Bryn Mawr Communications. So if you can please cue Dr. Fabi's presentation, and we can all get a little more educated on biostimulation. Thank you.
Welcome, everyone. We're super excited to have you this evening, where we're going to be covering Thriving in Chaos, specifically an update on off-the-face biostimulation in a post-COVID environment. Your faculty for this evening is myself, Sabrina Fabi. These are my disclosures, and then Dr. Stephen Diane, and you can see his disclosures as well. This activity is jointly provided by Medical Education Resources and SMD Consulting. Medical Education Resources has no conflicts to report. This activity is being supported by an educational grant from MERS North America. And this is the accreditation statement. This webinar activity can receive up to a maximum of 2 AMA PRA CME credit hours. And we'll give you more information on how to obtain that right here. So you'll attend the webinar, and then afterward, complete and return an activity post-test, which will be emailed to you, as well as can be obtained if you go to this link right here, www.cmesurvey.site/2020 webinar. A certificate of participation will be issued within 1 to 2 weeks following the meeting. There will be a question and answer session immediately after this portion of the presentation. Please don't take any photographs, as many of these patients have only given me their consent to utilize these photographs. Screenshots and recording is not permitted. So today, what are we going to be talking about? We're going to be talking about how COVID may affect patient outcomes after non-surgical treatments, discuss new protocols that should be in place for patients pre and post-treatment care regarding COVID, describe how to properly dilute calcium hydroxyapatite with saline and best practices for injecting it into the subcutis, as well as how to safely perform skin lifting using microfocus ultrasound with visualization in combination with injectable biostimulators. The educational activity may contain discussion of published and or investigational uses of agents that are not indicated by the FDA. This is our agenda. We're going to be going through the presentation now, and then we will be taking some question and answers before we go through the preparation for the patient treatment room in a post-COVID environment. Following that, we will enter the live patient demonstration where you will see injectable treatment using a biostimulator, how to prepare calcium hydroxyapatite with normal saline, as well as how to combine it safely with microfocus ultrasound with visualization. And after that, we will take more question and answers. Make sure to remember that you do have a question and answer tab at the bottom of your screen where you can enter your questions so that we can answer them throughout the presentation. So, why do we need biostimulators? Well, we know when we look at the skin that we're losing collagen at about 1% with every year of life. In a study of 350 women ages 20 to 70, approximately 2,000 genes were associated with exceptional skin agers, which many have coined super agers. When they looked at the skin throughout the years of those individuals, what they saw were changes that occur as a function of age when we look specifically at the skin is that there's a reduced antioxidant level in our 20s. And so we no longer have the antioxidant capacity to not only repair our DNA and repair that collagen that's degraded from UV as well as pollution and even blue light or infrared light with time, but we now, every time that we intrinsically are creating new collagen, we no longer have the reservoir to make that collagen, as well as now we don't have the antioxidant reserve. In addition, our skin bioenergy declines in our 30s, and in our 40s, we start to see cellular senescence, specifically of the fibroblast, which is the cell that creates that collagen. And so it's an opportune time to try to stimulate those fibroblasts to create new collagen. And we'll be talking about not just stimulating new collagen, but do these procedures actually stimulate new fibroblasts? And then we also see an impairment in skin barrier function in our 50s, which typically correlates with menopause. We know that with menopause, which typically in the United States comes on at an average age of 50, there is a decrease in intrinsic ability to create new collagen, not just at the level of the dermis, but also anywhere where collagen exists, whether it's the fibrous septae that run through that dermis into fascia, whether it's the fascia that enwraps our muscle, or whether it's our bone. And so there is a place for biostimulators. When we look at the fibroblast production of collagen, elastin, HA, as well as growth factors, we see them slow with age, but as I told you, they senesce in our 40s. While MMPs increase. By 60s, we also have altered microRNA, which causes abnormal cell adhesion as well as collagen synthesis. compared to someone who was perhaps less than 10 years old. And as dermal architecture weakens and UV damage accumulates, lymphatic endothelium loses its connection to the extracellular matrix. So we no longer can attenuate that UV-induced edema, which is why you see kind of a rubberiness to the skin. In a study of 83 biopsies of sun-exposed specimens, what they found was a decrease in type 1 and type 3 collagen staining from 82.5% as early as the first decade to up to even 44% in the ninth decade, respectively. Elastic recoil is also found to decline from 70% in our early 20s to 50% in our 70s. So it's not just thickness of skin, which correlates with that collagen, but it's the ability of that skin to recoil back that declines. And so we have many treatment options for patients as far as trying to thicken that dermis back up again and also make it more elastic. Historically, we have used some things like CO2 laser, which utilize heat. We know that the optimum temperature to break up the hydrogen bonds and disulfide bonds that hold those collagen fibrils together are 65 degrees Celsius. CO2 lasers deliver it at 100 degrees Celsius and not just stimulate new collagen through heat, but almost vaporize that top layer of skin, causing actual mechanical contraction of the skin. But the reality is that you get downtime associated with that procedure, and if that energy penetrates too deeply, all of that nonspecific thermal damage can cause pigmentary changes in our darker skin types, as well as potentially heat up our pilosebaceous units and cause scarring. As a result, we've evolved to radiofrequency heat, which came out in 2002 using externally applied monopolar radiofrequency, which can penetrate up to about 3 millimeters deep. But in order to not compromise the epidermis, which gets compromised at temperatures of about 50 degrees Celsius, there are certain cooling mechanisms in place, and so that bulk heat never quite reaches 65 degrees Celsius in the dermis where collagen resides. In order to overcome this barrier, microfocus ultrasound was developed and became available in Asia in 2008 and in the United States in 2010, where 2 ultrasound waves are focused at predetermined depths that were found to be ideal because our fascia, specifically our mass as well as our platysma, lay at either 4.5 or 3 millimeters deep. And so delivering 2 ultrasound waves and focusing them at these depths can deliver that optimal temperature of 65 degrees Celsius while preserving all the tissue in between, allowing us to safely treat darker Fitzpatrick skin types like Fitzpatrick skin types 4s, 5s, and 6s. Now, it's not just heat that can stimulate new collagen production, but it's also injectable. And so we know that calcium hydroxyl apatite has been found to show new collagen up to 96 weeks after injection. We know that PLLA as well as PMMA have also shown the same, and even hyaluronic acids, which historically create and displace tissue to create new volume and volumize the face, have also been found to create new collagen by stretching on those senescent fibroblasts and stimulating them indirectly to create new collagen. And we'll talk about how much new collagen is actually created by all of these devices. And of course, we always have our skincare products like topical retinoids that we have found stimulate new collagen, but they do it more superficially at the level of the papillary dermis, as well as devices like an IPL, where the heat doesn't necessarily come down enough to stimulate new collagen at the level of the reticular dermis and the fibrous septae that run through fat, as well as those fascial planes. And so when we talk about each of these individual injectables, although hyaluronic acid products historically have not been thought of necessarily collagen stimulators, but more of volumizers, we do know from a study that was published in 2013 in Journal Investigative Dermatology that there is a stimulation associated with an increase in mechanical forces that is created when you inject that hyaluronic acid into tissue, which is thought to elongate or spread the fibroblasts, mediating up an uptake of TGF-beta, as well as connective tissue growth factor. And so outside of the cosmetic realm, we have seen it involved in cell signaling, mesenchymal stem cell migration and differentiation, as well as fibroblast proliferation. And so hyaluronic acid gels, although not potent biostimulators, to a degree, do stimulate some level of collagen production. Calcium hydroxylapatite, though, is known to be a greater biostimulator and is used quite a bit in orthopedic surgery to actually stimulate new bone. And very similarly, because the osteoblast creates new collagen type 1 and type 3, very similar to the fibroblast in the dermis. And so in a study done by one of our dermatologic colleagues, Dr. Yoskovayakaya, sorry guys, I'll call her Dr. Yana, just to preserve the integrity of her last name, who's a good friend. She took a look at women, 24 of them specifically, between the ages of 35 and 45, and she injected 0.1 cc's of calcium hydroxylapatite into the midface, as well as supraperiosteally, preauricularly, and then she did punch biopsies before at 4 months and then as well 9 months later. And she compared one side of the face that was injected with calcium hydroxylapatite with the other side, which was injected with 0.1 cc's of a robust HA gel that's presently approved in the United States for the mid-face. And she measured for collagen type 1, 3, Ki67, a marker for new fibroblast cell proliferation, as well as angiogenesis and the lymphohistiocytic infiltrate that ensued from placement of both products. What she found was the calcium hydroxylapatite is indicated by the blue bar, and the hyaluronic acid gel is indicated by the gray bar. And you can see 4 months after injection, an increase in collagen type 3 staining, significantly greater in the calcium hydroxylapatite, which is the blue bar, than when compared to the HA gel. And at 9 months, you can see a decline in that collagen type 3, where you still actually see it going up at month 9 with the HA gel. When we look a little closer, you can see that at 9 months, this is now collagen type 1 being stained. How much more collagen type 1 is evident in the calcium hydroxylapatite group when you compare it to the HA group. So we know that calcium hydroxylapatite is a greater biostimulator, and here's just evidence 9 months after 0.1 cc's of the same amount of product of each gel. When we look at elastin, you can also see that at 9 months, as well as at 4 months, there's a greater amount of elastin that's actually produced as a result of the injection of calcium hydroxylapatite when we compare it to HA gel. And when we look at dermal cell proliferation as measured by Ki67, specifically looking at fibroblasts, you can see that at 4 months, we still don't see an increase in fibroblasts, but at 9 months, there's a significantly greater number of fibroblasts when compared to the HA gel, when we compare the calcium hydroxylapatite to the HA gel. Now, interestingly, when we look at the resulting angiogenesis, lymphohistiocytic infiltrate, as well as the edema, you can see how much more angiogenesis there is with the calcium hydroxylapatite at 9 months compared to the HA gel. But you can see the HA gel, again, marked by the gray bar, that has a lot more lymphohistiocytic infiltrate, so a lot more inflammation, which may be the reason why we see these late onset reactions, because there is some level of baseline inflammation that's brewing in the areas, and this may or may not have some type of correlation with those reactions. And so Yana took it a step further. So she recognized that there was greater biostimulation from the calcium hydroxylapatite compared to the HA gel, which we know, but no one has done the study on, and so she did it. And then she wanted to really investigate how much more neocollagenesis do we get from the calcium hydroxylapatite than what we're baseline creating on our own if nothing was injected. And so she took 0.1 cc's of calcium hydroxylapatite, but this time she diluted it. She diluted it either at a 1:2, 1:4, or 1:6 reconstitution with normal saline, and injected this again post-auricularly, and did biopsies at baseline and then again at 4 months to see how much new collagen was created, as well as did another biopsy at 7 months. She did an injection of 0.1 cc's of this dilute radius at baseline and then did it again at 4 months, because we know that in practice we commonly do repeat injections of biostimulators to get even more robust collagen stimulation. And so that's what she was trying to measure. And she measured it by using markers for collagen type 1, collagen type 3, elastin, and again looked at angiogenesis and CD34, a marker for fibroblasts. She also used ultrasound as well as a cutometer to actually see, okay, we know that there is greater staining of collagen type 1, but what does that actually measure as far as thickness of the dermis? How does it translate? And so here you can see that collagen type 1 at baseline, this is how much collagen we're all sitting here making with no injections. How much collagen type 3 we're making with no injections was denoted by the darker blue bar. And then how much elastin we have if we took a biopsy of our skin again with no treatments. And then after injecting 0.1 cc's of this diluted product, you can see at 4 months that you almost see an uptake of about 20% increased collagen type 1 and almost 30% of increased collagen type 3, as well as about 15% increase in elastin. When she injected a little bit more, so 0.1 cc's more of that dilute radius in the same area at 4 months, you can see how much more collagen type 1 we have at 7 months. And as expected, that collagen type 3 is now decreased at 7 months because it starts to get replaced by collagen type 1, typically around the 4 to 5 month mark. And you can see how much more elastin we have than if we had never injected any product, so almost 40% more elastin. When she corroborated this data by looking at ultrasound and cutometer measurements, you can see that you have an increased skin thickness that correlates with that increase in collagen staining. And so the epidermis, which is denoted by the darker blue bar, is the control. It remained the same the entire time. But you can see that the dermis is just getting thicker as a result of this injection by almost 30%. Thicker at 7 months. And you can also see that the elasticity of the skin is also almost about 40% more elastic at 7 months. And so in another study looking at the mechanism of action of this biostimulation, which was published by another colleague who I don't want to butcher their name, but this is in the Journal of Cosmetic Dermatology in 2016, they took 3 biopsies from 3 different female patients. Here they were actually in the more menopausal age group, 49 to 55, and they cultivated, fibroblasts were cultivated in the presence or absence of calcium hydroxylapatite. And so essentially they used TGF-beta as a positive control for an increase in contractile forces. They used this device to quantify the force generated by fibroblasts in collagen lattices. And they essentially evaluated the differences in contractile forces between normal age fibroblasts as well as wrinkled fibroblasts in the absence or presence of calcium hydroxylapatite. And so this is what the glass box looks like, which is essentially able to quantify force generated by fibroblasts. And here is where they, discerned the difference between a wrinkle fibroblast compared to a normal fibroblast. And you can see that a normal age fibroblast has greater contractile force than the wrinkled fibroblast. And that was statistically significant different. In the presence of calcium hydroxylapatite, that wrinkled fibroblast is able to have a contractile force that's almost what the normal fibroblast demonstrates. And when you compare and when you add calcium hydroxyapatite to a normal fibroblast, you actually increase its contractile force. And so this is essentially the premise as to why we do these biostimulatory procedures, not just in people where they have senescence of their fibroblasts in their 40s, but also even in someone with normal fibroblasts in their 30s or 20s that wants some level of neocollagenesis, where we know we're having a decrease in new collagen production. By adding a biostimulator, you can actually mimic or increase the contractile force of that fibroblast. Now, it's not just calcium hydroxyapatite that stimulates new collagen. We know that PLLA does the same. We've also learned a great deal of this from the orthopedic literature. In one study by one of our colleagues, Stein et al., in the Journal of Dermatological Sciences, they took 21 women, mean age of about 56.9. They took one vial, reconstituted it with 8 cc's of sterile water and 2 cc's of lidocaine. So they essentially had 10 cc's of product, injected it into the ventral aspect of the forearm of these women for 4 sessions, spread every 3 months, and then they separated the groups and essentially did biopsies in this interval that you see listed there. And what they found was a significant increase in CD68 positive macrophages as well as CD90 plus fibroblasts. And a substantial collagen type 3 was detected near the PLLA, and collagen type 1 was found in the periphery. What was interesting is that the PLA was still present 28 months later in some of the groups. And so PLLA, again, does increase biostimulation, but here the product itself is showing to be demonstrated much longer than we originally thought. PMMA is also used for biostimulation. In a study recently done just last year by Ronan in dermatologic surgery, they took 11 women, mean age 46, and essentially injected 0.1 cc's of PMMA into the abdominal skin. But here they injected it into the reticular dermis and did biopsies at the time points that you see listed there: 1 week, 1, 2, 3, and 6 months after injection. And they had 4 samples for each subject that they did this. And what they found was an influx of fibroblasts and new vasculature at all time points, where procollagen type 1 was already increased by month 1 and had organization through 6 months. There was not an increase in elastin. That measure was deemed to be inconclusive, but they essentially saw the microspheres and they remained at 6 months after the initial injection and became encapsulated with new collagen fibers. So here the microspheres do remain. And so we have a variety of these biostimulators, like you saw, all of them creating new collagen to varying degrees, some with more evidence to support their claim as biostimulators than others. And then we also have just energy-based devices that we know stimulate new collagen by a heat response. And so heat here creates a controlled wound that ultimately tricks the body to lay down new collagen. And so in a study looking to see how much biostimulation we get from the monopolar radiofrequency topically applied devices, our colleagues published in Journal of Cosmetic Dermatology just this year that after treatment with a monopolar radiofrequency device in 11 patients, mean age 48, and this matters because you know that some of these patients have more senescent fibroblasts. They treated patients using a device, specifically Thermage, using the new handpiece, and they were treating them with energy levels of 1.5 to 3, did the whole treatment, and biopsied before treatment and then again at 6 months. And they measured for collagen fiber density and coherence. And what they saw was a 5% increase in collagen fiber density in both the papillary and lower reticular dermis as a function of treatment. The density of elastic fibers in all parts of the dermis also showed a tendency towards increase after treatment, but here it was not statistically significant. We also have micro-focused ultrasound with visualization, which has been found to stimulate new collagen. In a novel way and to measure new collagen production, our plastic surgery colleagues colleague, Dr. Gordon Sasaki, had 2 subjects drink an isotopic tagged water, a heavy water, and had them drink it for 2 weeks prior to administering a treatment with microfocus ultrasound. He did 30 lines using the 4.5 millimeter depth transducer, and then 30 lines using the 3 millimeter depth transducer, just preauricularly. And he did biopsies before treatment and then after treatment. And he continued to have these subjects drink this heavy water for up to 4 weeks after the treatment. One side was treated while the other side was not. And what he essentially was trying to determine is how much more collagen type 1 and collagen type 3 is stimulated as a function of this treatment. And so you can see in the bottom 2 boxes, those are both 2 subjects. And you can see that there is an increase in collagen type 3 by about an average of 58% 1 month after treatment. And we would expect to see more collagen type 3 than collagen type 1, as we learned with some of the calcium hydroxylapatite studies. And then you can see an increase of already 25% new collagen type 1 as early as 1 month after treatment. And we would just expect that collagen type 3 over a period of 3 to 6 months to be converted back to collagen type 1. And so this is very much consistent with a study that was done by our South Korean colleagues who published in the European Society of Dermatologic Surgery in 2015. Sa et al. Essentially did a very similar treatment using the 4.5 and the 3 millimeter depth transducer, and biopsied the area 2 months after treatment and saw essentially a 23% increase in thickness of the reticular dermis, which correlates essentially with that increase that we saw from the heavy water study, and an overall 65.9% thickness in the dermis. What he also found was an increase in elastin fiber formation and a decrease in the fragmentation that you see. And so that's denoted by the 2 slides on the bottom right-hand side, with elastin being stained a little bit darker blue. And you can see how it's not as fragmented after 2 months after treatment. And so then the question becomes, if we have injectable biostimulators, and then we also have these energy-based devices, can you essentially, if many of patients have already been treated with some of these injectables, if we fire using microfocus ultrasound specifically, could we be breaking up the product? Or could we even see a synergistic effect? And so Gabriela Casabona, one of our dermatologic colleagues originally from Brazil, now in Spain, essentially took 0.1 cc's of an HA gel, 0.1 cc's of calcium hydroxylapatite, and then did nothing on a particular area of the thigh, and she injected it and immediately after fired a couple of lines with the microfocus ultrasound. Again, using 30 pulses of the 4.5 millimeter depth transducer, 30 pulses of the 3 millimeter depth transducer in a concentrated area where the product had been injected. And what you can see on the slides on the top right is that A and B show the HA gel immediately after being fired on the day of treatment. And then 6 months later on the right-hand side of that in box B. And you can see that the HA gel is perfectly there, has not been broken down. So it is safe to fire this over these products, because again, these products get sterilized at temperatures of about 125 to 134 degrees Celsius for up to 4 minutes. And so when you're firing at 65 degrees Celsius for about 3 seconds, it would take a lot of pulse stacking to really get to those temperatures, which none of us do if we're using the treatment correctly. So HA gel, fully intact. When you look immediately below at E and F, you can also see that the calcium hydroxylapatite is there as well after she fired on it immediately after, and then when she looked at it 6 months later. Interestingly, when she went to stain for collagen and elastin, what she found was that the areas that had a combination of treatment, both calcium hydroxylapatite and microfocus ultrasound had significantly greater new collagen production in the area than when compared to just the area that had the microfocus ultrasound alone. And as well as the HA gel. Those that had HA placed before treatment also had an increase in collagen as well as elastin fibers, just not as robust as the calcium hydroxyl apatite treated area. And so in conclusion, when we talk about calcium hydroxyl apatite compared to, let's say, an HA gel, which is not historically used for its biostimulatory properties, we see it stimulates about 20% more elastin fibers at 7 months than using the same volume of HA. And we know that calcium hydroxyl apatite stimulates about 40% more collagen type 1 at 7 months than when we compare it to 0.1 cc's of an HA gel, a thick, robust HA gel. We know that we see 15% more collagen type 1 correlating with an increased thickness in dermis at 4 months, and that increases to 30% at 7 months. And that there's 20% more elastin fibers and elasticity at 4 months when you inject 0.1 cc's of calcium hydroxyl apatite, and that doubles by 7 months. We also know that we see 25% more collagen type 1 at 1 month from treating with microfocus ultrasound, and 58% collagen type 3 when we do a treatment of microfocus ultrasound in as early as 1 month. And this correlates with an increase in thickness of that skin by about 66% at 2 months. And so I hope that these, this has been a pretty thorough review of all of the publications that are presently available on biostimulatory effects from calcium hydroxyl apatite, as well as some of the other gels or injectables such as PLLA, PMMA, as well as with microfocus ultrasound. And you can combine them safely on the same day, as I illustrated, based on the evidence that we have today to support this. And so now we'd love to take any questions that you may have.
So welcome back. I'm so glad. That was fantastic. I mean, I'm biostimulated right now.
For the nerds in all of us, that was just pretty much all the science, the most up-to-date review of all the science that's out there on biostimulation and why we do what we're doing. And we're really just taking from the orthopods, because they've been doing it for a long time now when trying to stimulate bone with calcium hydroxyl apatite, PLLA, as well as with growth factors and even with HA gels.
And certainly that's the future of aesthetic treatments right now, wouldn't you say?
Yeah, that's the future, because we recognize that not everybody can have many of these energy-based devices in their practice. Not all practices are designed to carry these devices. And so sometimes people resort to the injectable gels, which are easier for them to, hold in their practice to get these effects. As you can see, to a good degree, many of these gels do a good job in stimulating collagen, some better than others. And then some of the energy-based devices do a better job at stimulating collagen and elastin, some better than others. And so I think the ideal practice has a combination of both for the patient, but you can make do with what you have.
So we got a ton of questions, but we don't have time for all of them, because I know we're gonna get to the live demo and we have to get to the COVID protocols. So if it's okay, we can just have 3 or 4 questions for you.
Yeah, we'll take a couple of questions.
Couple questions.
Yeah.
So we're lucky to have Ben over here, so you can give us the questions.
Yes.
Okay.
From Atlanta, Georgia, of the energy-based devices, microfocus ultrasound and superficial radio frequency, which is the most painful and which causes the most inflammation?
Repeat.
Can repeat?
Of the energy-based devices, ultrasound versus radio frequency, which is the most painful for the patient?
Of the energy-based devices, which is most painful? So there's a couple of radio frequency devices. There are the externally or topically applied RF technologies. And if you decrease the energy in those devices, then they're not as sensitive to the patient. But if you treat them at the energy settings necessary, they can be quite painful. And so can microfocus ultrasound. In clinical trials with microfocus ultrasound, the pain level historically is about 4 out of 5 out of 10 with the 4.5 millimeter depth transducer, and 3 to 4 out of 10 with the 3 millimeter depth transducer. And we're doing a clinical trial right now that if you actually visualize fascia and you target based on you treat based on target, you see significantly less pain than if you're just using the deep transducers and possibly treating digastric muscle of the neck, or you're treating bicep muscle when you're treating the arms. So what you're visualizing makes a difference in mitigating that pain.
So we use nitrous oxide oftentimes. It makes the patient more comfortable. Is there anything else that you use that makes the patient more comfortable?
Yeah, so historically we always used intramuscular Demerol Phenergan, and an oral Valium. And what we found was that when we introduced Pronox into our practice, which is a blend of nitrous oxide, 50% nitrous oxide, 50% oxygen, the pain was significantly reduced, even more than a narcotic intramuscularly. We can't explain why. We know that nitrous puts you in a more dissociative state. And the nice thing is that it dissipates quite quickly. I mean, within 10 minutes, it's pretty much
So they can
out.
actually drive home if they're not just using nitrous, actually.
Right. I mean, it depends, where you practice and the state that you practice and, the legality that you want to take on. But pretty much most people are back to, work and business in about an hour.
Okay, but one thing I want to mention about, you said of opioid and benzodiazepam. I used to be on the state medical licensing board, and I was surprised to hear that sometimes in some states you can't give both in an office. So check with your state about what you can offer in that situation.
Absolutely. And then be careful with combining a benzo and a narcotic with Pronox, because all of these things have an effect on overall respiratory depression. So you have to be very careful and take a good history for your patient. But nitrous has been excellent. There are some that do get a bit of nausea from it. And so if you have Zofran in the office, that's a nice choice that's worked really well for the very few that do experience that. And I know you're going to be covering how to handle Pronox and how to handle it with a filter, especially now when there is so much concern of blowing out.
So I'm going to show you ways to do it safely. And we have a filter that reduces 99% of the bacteria and viruses that go through it, so the patient and you can both be safe.
So I think we have another question.
We have a bunch of questions.
Okay.
There's a good one about laxity from Mariana. PLLA versus calcium hydroxyapatite specifically for laxity.
So thank you, Mariana, for asking the question. There are presently no head-to-head studies comparing PLLA to calcium hydroxyapatite, neither on the face nor on the body. Most of the literature out there is with calcium hydroxyapatite on the body. There are some publications in the literature with PLLA. One publication by Neil Sadek, where he did 3 sessions of PLLA on the buttock, and that study was looking more at volumizing the buttock than for true skin laxity. There's another study by Neil Sadek on the abdomen, where again, he used PLLA to improve skin tightening. That was a smaller study, where there are now 2 studies on the abdomen using calcium hydroxyapatite by Pavlenko and JDD, where they did a cohort of 10 patients using calcium hydroxyapatite. They only used half of a syringe of calcium hydroxyapatite, so 0.8 cc's of calcium hydroxyapatite, blending at a 1:3 dilution. So overall had a total of 4 cc's of product, so 0.8 cc's of calcium hydroxyapatite, 3.2 cc's of normal saline, and injected it periumbilically. And then they did ultrasound measurements 70 days after 1 injection. And what they saw was a thickness in that tissue by about 26%, and an improvement in that tightening of the skin of the abdomen. And so in that study, almost 100% of the patients reported improvement, very much improved on the Geist scale. And so presently, when it comes to true skin laxity on the body, the only other thing we have is a study by Pavlenko again for the arms. And we don't have anything for the arms when it comes to PLLA. I did a study with PLLA on the knees. There we did see some improvement in overall laxity, and that paper will be published in dermatologic surgery by the end of this year.
Okay, wait a second. How do you remember all that stuff? Like, where do you store all that? And if you give me a ton of information and I can't even keep track of all of it, if I want to get that, where do I go to get it?
So I've published a great amount of this.
Okay.
So you can just PubMed me. And you will see a lot of the literature, because I do both. So it really comes down to, are you trying to volumize or are you trying to tighten the skin? And so when you're trying to volumize the buttock, I use more PLLA because there's more literature to support that. When I'm trying to tighten the skin on the inner arms, there's more literature with calcium hydroxyapatite. So I use
So you do both?
Yeah, so I do both. And I really base it off the evidence. So hopefully we'll see more with PLLA. For now, there's a lot more published with calcium hydroxyapatite.
And if they want more information, they can PubMed you and get your articles.
Or you can just Instagram
DM
me.
us.
Yes, on Instagram.
Okay, we're running out of time because we got so much to do.
One more question.
Fine, one more question.
Great question from Marina. She says, are you using these currently now with the COVID environment?
Great question, Marie.
Yeah, so that's Marina.
Marina, correct.
Marina is asking if we're using, actually I've found that injecting on the body is, people feel more comfortable on the body than they do getting injected on the face, especially in this post-COVID environment. That's the reason why we're doing this live demo for you today, because this has been an area that where both patients as well as doctors feel more safe, because patients can retain their mask as you're injecting them. In Southern California, we opened up on May 1st. And so patients have actually been coming in quite a lot. Maybe they've had a lot of time at home. Maybe it's because they want to do something for themselves, because we recognize that it's not just, that treatments aren't just facing wrinkles or tightening skin, but people actually feel better from these procedures.
I'm a facial plastic surgeon.
Yeah.
I will tell you that I specialize in the face. So I'm seeing a lot of patients coming in, much more than I ever imagined. So they want facial treatments also. And that's why it's so important we go through these COVID protocols with you. Today, we're going to do body and we're going to show body. But next time, in the next episode, we'll show you face. I got a lot of nifty tricks for you to show you how to do it safely in a COVID environment.
But yeah, Marina, I am doing all these treatments right now, and patients are actually asking for them more than ever. Maybe because they can't get their nails done or they can't get their hair done, and so they can't see me, and they're home.
They're home, yeah.
So they're seeing this. And can we take one more question?
Kelvin asks, he has been using Radius for a long time.
Yep.
Is he missing out, not combining it with Sculptra treatment?
Okay,
Radius
so
without Sculptra?
He's using Radius. He wants to know, is he missing out by not combining both of them?
I haven't used Sculptra, but I've been using a long time user of Radius. Okay, so thanks for joining in, Calvin. I think that there's a place for everything. I use everything in my practice. I think it depends what you're trying to use these products for. And so if you are somebody who's trying to really treat like really superficial skin laxity, inner arms, perhaps inner thighs, even abdomen, I do really like dilute calcium hydroxylapatite. If you're looking for more volume, I do like PLLA, and that's because there was one trial that was done where they injected PLLA and they actually saw that around the macrophage, you started seeing an increased production of adipocytes. So there's something there where it's stimulating adipocytes, and I'm not quite sure why. So from a volume perspective, if you're trying to augment the butt, my go-to is usually PLLA. When it comes to chest wrinkles, it's a split. I've gotten the same results with doing PLLA as I have with calcium hydroxylapatite. So it really comes down to, you know, what technique you feel more comfortable with.
Is one more of a biostimulator or like a fibroblastic versus a fibrotic response?
So historically, people have said that, yeah, you know, calcium hydroxylapatite is more of your fibroblastic response, where with PLLA, you may get more of a fibrotic response. And in that article that you saw me cite with PLLA, the authors noticed that the PLLA molecules were still there 96 weeks later, and it actually induced more of a fibrotic response than they had anticipated. But there's still no head-to-head study. If you look at the face, people love PLLA because it does, maybe that fibrotic response is what causes all that contraction. But I think in my hands, I really love both, but my go-to in the inner arms, abdomen, and chest is calcium hydroxylapatite.
So can we see you do it live today?
Yes.
Okay, so while you get set up, we're gonna take you through the office and some post-COVID environments. This is really important. Keep in mind, this is fluid, things are changing every single day, but this is the current standard of what we're doing. And I think you may learn a lot from it, and it may be valuable. Once again, any questions, DM us. We'll be taking questions soon. And also join us for Instagram Live afterwards, where we're gonna really get into the questions.
But make sure that you use your question and answer function on your Zoom today. We love taking your questions, and thank you for tuning in.
Welcome to my office. Come on in, I'll show you. Welcome to my office 2020 post-COVID. Let me go through our protocols and show you what we're doing. Out front right here, standing 6 feet away from my receptionist, Jasmine. She's gonna ask me some questions and she's gonna take my temperature. Now, the patients have been pre-screened. So one day prior to them coming in, we've already asked them questions to make sure they have not been exposed to COVID or they're having symptoms of COVID. If they pass that, they show up on the day of the treatment and they meet Jasmine. And Jasmine, what are you gonna ask me?
I'm going to be going through some of our wellness questions here. I'm first going to be taking your temperature.
Okay, so you take the patient's temperature. So if it's greater than 100.4, we don't allow them into the office. Now, when they're out here, they should be wearing a mask. All patients are required to wear a mask in our office. Many people are wearing their own mask. However, if they don't have a mask, we actually have masks for them. These are 3-ply masks. We also have hand sanitizer out here. And we provide the patients with hand sanitizer before they walk in. If Jasmine determines that they're okay to be in the office because they pass our screening, Then she will escort them into the office, and that's where we're going next. I do want to mention this article, ACERT. It was an article that was published by a group, a consensus group of aesthetic physicians, recently published in Facial Plastic Surgery and Aesthetic Medicine. And these are the guidelines that we're mostly using. It's a fantastic reference. I highly recommend you all get it. It's free. You can get it. It's access free. And if you go to the journal website, you can get it. All right, Jasmine, let's go into the office.
Okay.
So as you notice here, we have a doorbell, and this button gets pushed if someone's out front. Then we will not let them in unless they get screened out by Jasmine before they come in. So if no one's out here, doorbell. We may walk the patients through this room. However, we do not use this room because this room is our old reception room. Of course, if someone sits here, you can see that we want to have at least 6 feet between them. But once again, this room is rarely used anymore. Now we're going to enter into the office. And the patient is brought right into the room, and they're going to sit right there in that chair. I'll get to that in a second. Prior to going into that room, you can see these are some of the supplies we have here. These are for the providers. So I myself may be wearing this mask, which is a TheraMask, or this N95 mask. All providers who enter rooms with patients are wearing N95 masks, whether it's a neurotoxin, a filler treatment, or a treatment that produces aerosol. They'll all be wearing N95 masks. Some of our staff wears a mask over it, a 3-ply mask over it, if they wish. We have goggles. This is for all doctors and all providers and all medical assistants when they enter in the room. Or they may use a face shield device that we use here. And this protects the face also from any splatter. We have a cap and we have a gown. These are some of the gowns we use. However, we have more disposable gowns that are on their way so we can go in and out of rooms. And frequently we'll ask the staff to wear a gown when they walk in the room, especially if we believe it's an aerosol producing treatment, such as a ablative laser treatment, even laser hair removal, or even some of our products, our dermabrasion treatments. Once again, we're following the certification guidelines that are put together from ACERT, and that's the article in Facial Plastic Surgery and Aesthetic Medicine. All right, come on into the room. I'll show you some things we're doing in the room. So this room is getting wiped down after every treatment. We separate our patient visits by 30 minutes so that we make sure the room is completely clean between each patient visit. And what does it get wiped down with? We're using hypochlorite acid. Okay, come on with me back here. Let me show you some of the things we're doing. So this is a solution that includes 4 cc's of iodine, 40 cc's of water, and 28 cc's of Colgate. This will give me a solution of 0.5, a little under 0.5% of iodine. Patients gargle with this for 30 seconds prior to me treating them if I'm going to be treating the head and neck. We also have an atomizer here, and we take up about 2 cc's and we put 1 cc into each nostril, and we draw up 2 cc's, put on this little atomizer, and then put it into the nose. This is hypochlorous acid. So hypochlorous acid is recognized to kill 99% of all viral and bacteria. It's incredibly powerful and incredibly effective and incredibly safe. I can spray it on myself. In your eyes, in your mouth, and there's many times a day where we'll spray it. I'll even put it in my nose, in my mouth. And one of the things I may do here in the office is I may take a 4x4 and I'll soak it. And I may put this over the patient's mouth if I'm injecting them in the upper face, above where the mask would go or below where the mask would go. But I'll show you more of that in episode 2. So stay tuned for episode 2 where we show you how to treat the face. For episode 1, we're just going to be showing the lower third of the face. This also is a filter. My good friend Steve Weiner created this. So this filter filters out 99% of bacteria and viruses. And the patient can put this in their mouth and they can breathe while we inject them. And then we have a nose clip to put on their nose at the same time if we want. So I'll show you how to do that on a patient later on, especially for episode 2. So that's a little bit about some of the prep that goes into the patients. Of course, we have gloves. We're always wearing gloves for every patient visit. That's similar to what we did prior to COVID as well. Okay, each room also is equipped with a HEPA filter. That circulates the air 5 times every hour, and that reduces 99% of the bacteria or viruses larger than 0.3 or particles larger than 0.3 microns. Now keep in mind that the SARS-CoV-2 virus, which creates COVID-19, the infection, is very small. It's 0.125 microns. However, oftentimes it gets stuck on droplets, and if it gets stuck on a droplet, then it's often larger when it's transmitted. Particles that are larger than 5 microns are large droplets. Those fall to the floor. Smaller particles, less than 5 microns, can be aerosolized, and those are the ones we're more concerned about. They do get picked up by the HEPA filter, and it circulates 5 times an hour. Look at the CADR, C-A-D-R, that's a qualification, what helps you determine what size HEPA filter we'll use for your room. For our purposes, this filter is small, but it's up to rooms of 100 square feet, and we're satisfied with that, and it's not very expensive. We also use a UVC light, and you can see this over here. So ultraviolet C rays destroy over 90% of bacteria and pathogens. Ultraviolet C rays are in the 260 nanometer range. They're very, very damaging to DNA and RNA, and you have to be careful so no person can come in the room. So in between patient visits, the room is completely sterilized with the ultraviolet C rays. We put that on. It runs for 15 minutes for rooms less than 200 square feet. So that's why we have this size, the 60-watt bulb, and we run the ultraviolet C rays, HEPA filter, and then afterwards, the patient can come into the room. So that's why we have 30 minutes between patient visits, so we make sure the room is sterilized. This here is the Pronox device. If we're going to use a Pronox device, we want to make sure we have a filter. So we have our system set up here so that we can filter 99% of particles that enter the patient's airway or that are expressed from the patient's airway. This goes into there, and you can see this is the exhaust. This is the filter that goes here. And then the patient can breathe right through there. So this is how, and this goes to the patient. This filter here takes out 99% of viruses and bacteria. So they can breathe in, breathe out. If they maintain themselves on there, we should be okay. If they take this off, we ask them to put their mask back on. I may have the buffalo filter going, so you don't even catch a second of aerosolized products. So we will be using this with our treatments when we do the lower body treatments or if we do procedures in the office. Every 10 to 15 minutes, we're wiping down these again with the Clorox wipes, and that has been proven effective against the SARS-CoV virus. And as I check out, oftentimes patients prepay, but if they don't prepay and something has to be done at the front desk, it will be done. We make sure, once again, there's hand sanitizer up here. We have sanitized and unsanitized pens, so we're careful with that. The patient also gives us, we have a contact tracing, so we know who they saw in the office. So we call them 2 days and even up to a week and 2 weeks after the treatment to make sure that the patient's doing well. If they complain or have any symptoms or have been exposed to SARS-CoV-2 or COVID, we ask them to tell us about it, and we make sure that our staff has been appropriately notified if they have come in contact with someone who has turned positive. All right, we're ready to get started, and there's Dr. Fabi.
Hi, everyone.
So
So
now,
I'm all gowned up now.
your glasses are on perfect. They look so good. Are those Chanel?
Yeah. No, but if Chanel's out there and they're watching,
Okay.
please make sure, yeah, to create some better ones
Okay,
for
so
me.
you can see that Dr. Fabi is completely PP'd up. She's wearing an N95 mask, a cap and gown. These are the certifications, or these are the recommendations by the ACER article, which recently came out in Facial Plastic Surgery and Aesthetic Medicine. I highly recommend everyone reads it. I think it's a very valuable reference to know what to do. So this is a non-ablative procedure, and this is what we're going ahead and doing. So Dr. Fabi, can you introduce us a little bit to the patient,
Yep.
what you see, and what your plans are?
So we have a beautiful patient, and she's obviously gone through the screening already criteria for being seen as a patient here that you saw Dr. Diane and kind of go through. And so she's your ideal patient for dilute calcium hydroxylapatite. She would be someone that if she came into my office, what she's already told me before is that she's bothered by these wrinkles, but she's also bothered by all of this dyschromia. So in someone like her, I would first, on the same day, I would do photofacial or IPL to address that dyschromia. And then on the same day immediately after, I would do dilute calcium hydroxylapatite. If she had more severe wrinkles, then I would actually do photofacial, microfocus ultrasound, immediately followed by calcium hydroxylapatite.
Okay, so why that order? Why do you go in that order?
Right. Well, I like to do IPL first because therapy or microfocus ultrasound can cause a little bit of erythema. And so it might pick up the erythema after you've done the microfocus ultrasound. And so if you look at our consensus recommendations published in November of 2016 in dermatologic surgery, we recommend doing a non-ablative laser first, like an IPL, and then you can do your microfocus ultrasound. And then immediately after that, I do my dilute calcium hydroxyapatite. And so she's got more moderate wrinkles, so she would do well with just microfocus ultrasound or just dilute calcium hydroxyapatite. She's not someone where I'd necessarily do both unless she were more severe. So it depends what you have out there. So if you have microfocus ultrasound on someone like this, I would essentially, and what I do is I like using the little stencil that comes with the device. You can feel the sternoclavicular joint. And this is the same area that I essentially also use to treat with dilute calcium hydroxyapatite. Because let's be honest, it's not like you usually see wrinkles out here laterally. They're usually always in the central aspect of the chest. And if you start working your way up beyond the sternoclavicular joint into the neck, you have to change your dilutions with calcium hydroxyapatite in the neck because of the platysma muscle and because that dermis gets even thinner and the space between the dermis and the platysma gets even thinner. So this is the area where I would treat with either dilute calcium hydroxyapatite or with microfocus ultrasound. Just to demonstrate, what we did was a study in our practice where we took one group of patients, we treated them with microfocus ultrasound or calcium hydroxyapatite or a combination of both. And what we found was that in the group that had a single treatment with microfocus ultrasound, they had significant improvement in their wrinkles that lasted up to a year. So what are we treating when we're treating the chest? So we're going to go to the screen. We're going to keep the screen right there. We're not going to move the table. And camera one is going to go to the Ultherapy device. And if we're going to zoom in so that everybody can kind of see what we're trying to treat. And here you can appreciate how thick her dermis is. So her dermis for the chest is almost 2 millimeters. We're going to stop and hold it right there. And you can see that fascia. And look at her. She's got her Cooper's ligaments running, and we're not going to move the camera anymore. And you can see those Cooper's ligaments running along 3 millimeters. Because if you remember, Cooper's ligaments are what run from the superficial fascial system that enwraps the pectoralis muscle to the dermis. And those are made up of collagen. And so they are also not intrinsically creating and turning over collagen with age. And so not only do you get wrinkles, but you also have ptosis of the breast. So even if you are 40 and you've never had babies and you haven't had a lot of weight change, your breast will become more ptotic. And so the nice thing with microfocus ultrasound is that you can get to this level to treat those Cooper's ligaments. And that's why in the original pilot trial, we actually saw about a 2 centimeter lift in the breast by just treating this area. So in someone like her, I would treat with the 4.5, and then I would change my transducer. We're going to keep on that screen. I'm changing the transducer. So that was using the 4.5. And now I'm switching to the 3 millimeter depth transducer. And you can see again, so she's very, she's a very unique patient, not like the ones that I see in San Diego where their dermis is about 1 millimeter. The average dermis of the chest is 1.3 millimeters. Her dermis is like 2.5 millimeters.
Is that because people in Chicago have thicker skin?
I think you need it in Chicago. In San Diego, you don't need as thick of skin. So maybe that's why it's almost half as thick. But nevertheless, someone like her, I would do the 4.5 and the 3 if I were trying to lift her breast. I would use the 3 and the 1.5 if I were trying to improve her wrinkles. And she would do extremely well.
How important is visualization? Because here you're telling me about these 3 and different millimeters for different patients from different parts of the country. Can you do this without visualization?
So coming back to me, Essentially, this is what I always tell people when they learn from me, you know, all over. It's like, how important is it to visualize a face when you have a needle and you're trying to augment the cheek, right? It's really important. No one injects blindfolded, and so the same goes with microfocus ultrasound. Even though you don't necessarily see the heat or the vaporization of tissue like you may see with CO2 lasers, it doesn't mean that you're not delivering 65 degrees Celsius of heat. So you have to be mindful of where you're firing that energy.
So what happens if you don't hit the structures you're trying to hit? You don't hit the fascial layer.
So what I tell patients is, what if you use a pulse dye laser to treat a cherry angioma, and the cherry angioma is on the nose and you're firing it at the ear? Are you going to get to the cherry angioma on the nose? Probably not. So you're going to have a patient that's going to come back and be like, Doc, I didn't see a change. So that's why visualization is important.
What about the learning curve? How hard is it to learn to read the ultrasound, and how hard is it?
I think it depends probably on your level of comfort with anatomy and ultrasound energy. But for me, it took about 10 treatments in order to get that. So that's, you know, so first I would start with microfocus ultrasound like you saw me do there. And now I'm going to prep her skin.
Notice she's using chlorhexidine here. And this is a common treatment. You're also using isopropyl alcohol.
Yeah, so we're using a little spray of isopropyl alcohol.
So isopropyl alcohol has been shown to be virucidal to COVID, SARS-CoV-2. Chlorhexidine is not as good, so we're often recommending in our office now using hypochlorous acid, which I'm a big fan of. So we're using that because it is shown to be effective against SARS-CoV-2 in Australia, and in the U.S. it's been shown to be virucidal. So we're using that, and betadine also, or povidone iodine, has also been shown to be effective against the viruses. So those are what we're using.
Okay.
Is that local?
So now I do a little numbing dot. And so here, this is how I approach anytime I do injectables to the chest. I do my little, you know, marking, which essentially is in alignment with midclavicular line is typically my most lateral points. The fourth rib is usually my most inferior point. I drop a line diagonally to meet along the cleavage, which is where most of the wrinkles are. And so this is the area typically of sun exposure. So I'm just doing little micro drops of lidocaine with epinephrine. We have to remember that the chest is covered with reticular veins. In fact, I do a lot of sclerotherapy to these reticular veins, especially after breast augmentations. I find that they become a little bit more pronounced. And so you're running your product in that subcutaneous plane, in that fat plane. And you saw with her that that fat plane is only about 1 millimeter. And so here, I think it's important to use a cannula. And so I'm using a 22 gauge blunt tipped 2-inch long cannula. And this is something I learned from you. Because historically, I was
one of the things you've learned from me. There's a
one
lot
of
more.
2 things that I've only learned from him. So essentially, of the one of 2 things that I learned is that a 25 gauge is more likely to penetrate into an artery. And so,
great article by Sebastian Codofano on that. Highly recommend it, showing how easy it is for certain cannulas to get into the vessel. And 27 gauge cannula is equivalent to a needle getting into a vessel. So I'm a big fan of 22 gauge cannulas.
And so I, you know, also publish on getting into the infraorbital artery with a 25 gauge cannula. And so because of that, I switched to a 22. Now I want to be very clear. I don't want anyone to have a false sense of safety. A 22 can also get you into an artery, just less likely. So don't ram the cannula into the body of the patient. Be gentle, you know, because if you're exerting a lot of force, I'm sure you can penetrate the arterial wall. And so I've just used a little introducer. I like Kent Remington's technique of, you know, counting for 10 seconds. And then before I enter now, and so I like to stretch out the skin. And if I'm feeling or meeting any type of resistance, I'll use the introducer again.
Okay, can I ask you a question from the audience here?
Yes.
So we have a question from Marissa. Where do you obtain the filters for ProNext device? I'll answer that question.
Yep, please.
We get that through our distributor here. And if you DM me, I'll send you that name and I can get you more information on that. But Lisa is asking you, can you lift her breast with microfocus ultrasound? It seems a little far-fetched.
If you take a look at our publication in the Journal of the American Academy of Dermatology, published in 2014, you can take a look and see what we did. If I don't think it's far-fetched. You know, I always think of just the anatomy that we know. Anatomy hasn't changed. What holds up your breast? Cooper's ligaments. What are Cooper's ligaments made of? Collagen. What's intrinsically degrading as a function of age? Collagen. What are you doing to stimulate collagen at the level of Cooper's ligaments? Not much. So if you thicken up that tissue and you get some contraction, can you get about a 2 centimeter lift? Yeah. A 2 centimeter lift on a 36 double E patient, probably not a breast lift. A 2 centimeter lift on a BMI of 21 with a C cup, yeah, you can get something. And so that study, what we saw was that patients were of C cup and their BMI was about 23. So it's not that things don't work, it's just that we use the knowledge that we have to use the treatments that we have to trick the body to do the things that we want it to do.
Were patients satisfied with that? Do they really actually feel like they got a breast
Oh
lift?
yeah, patients were ecstatic about it. So in that trial, 90% of patients showed an improvement. And that lasted for up to 6 months.
So I'm sure it's not a surgical outcome, but certainly it may be something you could offer to someone.
Absolutely,
As an adjunctive,
because what's the alternative? Surgery. And so does everyone want surgery? Not necessarily.
Okay, can you talk to me a little bit about the plane you're in and where you're injecting in?
Right, so we know that I'm injecting into the subcutaneous fat, right? It's pretty much impossible to run a 22 gauge cannula in a dermis. And she'd be jumping out of the chair if I were running it through her pectoralis muscle. I'll use the introducer.
So what are you worried about as you're in that plane? Is there
So
any
in that plane, we're not so worried about arteries. Those run typically more on the muscle, which is why you don't want to jab them, because you could get into it if you're not aware of the plane that you're injecting. But that's why I do like cannulas here more than needles, because you can have more confidence that you are running through the subcutaneous plane. Now, what you do have there are reticular veins, actually quite a number of them. And so there you can get a fair amount of bruising is what I have found. So sometimes I'll use like a topical arnica, and you saw how thick her tissue was. So even though I leave it in for like 10 seconds, you can see me having and meeting a lot of resistance. So I'm going to use the introducer again. Do we have any other questions?
Yes, we do. If someone has come in contact with someone who's germ positive, how long do you wait for them to become cleared before you let them into the office if they show no symptoms? So thank you, Calvin. I think that's a great question. We actually just came up with some protocols on that recently. And what we're doing is we're saying 10 to 14 days, they have to have no symptoms, and then we let them come back into the office. Same thing with staff members if we feel that one of them has been exposed as well.
So when I'm in here with my cannula, I like wiggle the cannula. So you can see I come out and then I wiggle my way through. So you're going to see in a moment.
You inject just on withdrawal?
I inject in a linear retrograde fashion. I don't jab. Like if you jab, then you don't know where the tip of that cannula went.
I want to just comment on that. I think that's really important, because one of the things I've noticed is that when you put a cannula in, whether it's the face, the chest, anywhere in the body, there's a softness to it where you kind of work it softly through. And I've learned this a lot when I was injecting hands, because you can see the cannula work around the vessels of the hand, and you can see yourself bounce off the vessels. And if you go slowly and kind of work around it, then you see that you can be very safe. I know as a surgeon, we're often working around large vessels, and you have to learn how to be delicate around the vessels. The same thing goes with the cannula. It's really important you don't do a jabbing motion. You kind of knead it through very carefully, and I think that always works well. And you can see Dr. Fabi doing that here as she injects the chest.
So right now, I'm just getting more.
So I got another question here. What is the mixture for the mouthwash? And is this done for all the filler patients? Okay, great question. Yes, I'm doing a mouthwash. Now, I am doing it on all my filler patients certainly if I'm going to bring down their mask, which I do when I do the fillers. I have a whole protocol for that, which I will show you in episode number 2. But what in specific, I mix a combination that I came up with based on papers I've read and some of my colleagues. So I use a combination of iodine, betadine, and I take a 7.5% solution, and I put in 4 cc's of that. I include 40 cc's of water and 28 cc's of a mouthwash that's alcohol-free. And I mix that all together, and then I take 10 cc's of the mouthwash. I have everyone gargle with that. I do it 3 times a day, to be honest with you. I also inject it into people's noses with an atomizer, and I can show you that as well. I picked up some of those online. And the atomizer, I put into the nose. I put 1 cc into each nostril. My MAs prep the patients before I walk in, and I can give you more information on that in the next episode, or if you DM me, I'm happy to send you my formulas.
So essentially with her, you saw me initially when I did my dilution, I did 1.5 cc's blended with 1.5 cc's of normal saline. So in someone who has thick skin like this, I'll do a 1-to-1 dilution. In someone who has thinner skin, I'll do a 1-to-2 dilution. And in the clinical trial that we did with calcium hydroxyapatite, we did a 1-to-2 dilution.
What about lidocaine? Did you put any lidocaine in there?
No, this is Radius Plus. So she did not, it already has a little bit of lidocaine in it. But if you do classic Radius or classic calcium hydroxyapatite, you can add like just 0.2 or 0.3 cc's of lidocaine. You don't need a lot. The chest and the body in general don't need that much anesthetic.
Yeah.
Any other questions?
So do you find the chest is less sensitive than the face?
I do find that the chest is less sensitive than the face. Yep.
Okay.
We just probably don't have as many nerve endings.
Okay, let's see if we have any other questions here. Okay.
And this is kind of how I work my way. So I start into these 3 lateral points, then I have these other 3, and then I'll come on to the other side. I'm only going to treat half of her chest, and then I'm going to start with her arm.
Okay, so Lisa asked, how many syringes will you use in one setting?
In her chest, usually I'll only need about 1 syringe. When it comes to the arms, I may do anywhere between 1 to 2 syringes or 1 to 1.5 syringes per arm. And in the arm, I'm doing a 1 to 2 dilution. And it just depends how much laxity they have and where they have, like and you'll see like on her arm, for instance, she has this laxity right through here. Some people have laxity that comes all the way down to their elbow and comes all the way back here. In someone like that, you're going to need 2 syringes of calcium hydroxyapatite. But with her, she'll probably just need 1. And I'm going to dilute it at a 1 to 2 because you can see that the skin of her arm is a lot thinner than the skin of her chest.
So do you ever treat outside your hexagon right there, or?
I don't feel like you need it. I feel like it's like a wasted product if you do. So.
All right, we have a question also here, and this is from Calvin. Do you think that IPL aerosolizes particles? So do I think IPL traditionally, no, not necessarily if you're going after brown spots or red spots. However, having said that, every time you touch the skin with energy, there's a potential to hit a hair follicle or on something on the skin that may create aerosolization. So we are using maximum PPE when we're doing IPL as well, and that's based on the guidelines from the ACERT article that I mentioned earlier in facial plastic surgery and aesthetic medicine by Jeff Dover and the other colleagues in aesthetic medicine. So I do think that maximum PPE should be used for that as well.
All right, so I treated half of her chest. She's doing great. And now we're gonna go to her arms. And this is an area where, again, you can do microfocus ultrasound. In my experience, my go-to in this area actually is dilute calcium hydroxyapatite. I just haven't seen as great of a result with microfocus ultrasound here, not as consistent as I see on the chest. And so this is an area, I'm gonna have you relax your elbow, just drop it, exactly. And so I'm gonna have you stand up. And so there you go, just like that. And just sit up a little bit more, just like that. And so this is like, you see this waviness through here? If we can come to camera 1, this waviness through here is what patients complain about. They call it cellulite. Now, cellulite, we know, is a term that is incorrectly used, unfortunately, by many people. It's not just dimpling, but it's also, you know, the skin laxity that we see, especially in patients over the age of 30. And so I'm going to keep the camera and the lighting just like they are right now. we're not going to touch it, so that you can kind of see it, because it's in that shadow that this is where patients see it the most, right? And so I like to mark patients generally when they're standing or sitting up, just like she is. And we see it in the inner arm much more than laterally. And that's because you have your tricep muscle back through here, and you have your bicep muscle through here. So you have a lot more muscle and thicker fascia that's holding everything together. But in the inner arm, you don't have that luxury. So you have this cottage cheese appearance that drives women crazy, and you don't have many options. You can do a brachioplasty, and then you leave them with a long scar in the back of their arm, and that defeats the entire purpose of doing anything, because the reason why they want to do something is that they want to wear dresses. And now you can't wear dresses because you have a long scar. So either way, you're kind of, you know, you're wronged, right? So in this area, I really like calcium hydroxyapatite. Now, what's my rule of thumb when I'm treating this area? So essentially, for anything that's the size of my hand, I have a small hand. So in the trial that we published, so anything that's about 100 by 100 centimeters, so 4 by 4 inches, that is going to essentially get 1.5 cc's of undiluted product. So in your mind, you figure that out. So
wait, can we just go over that again? Because I think it's really important. Everyone's always asking how much product to use.
Yeah.
So if it's the size of your hand,
if
using 1.5 cc's, that's 1 vial of calcium hydroxyapatite.
Right. Undiluted. Okay. So I generally, people are like, how much do I need, or how much it's going to cost? Well, it really comes, we're going to leave everything just like it is right now. So it comes down to how much area is affected. If this is how much area is affected, then I mark it first, and then I take my hand. She's perfectly the size of my hand. So in her, I know that I'm going to need 1 syringe of 1.5 cc's of calcium hydroxyapatite.
Diluted.
Undiluted.
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 But you dilute it before you
But
inject it.
now what's going to determine how I dilute it is how thin is the skin. So in her, well, I have my microfocus ultrasound, so we can actually do it right now and figure it out. So I'll take the 3 millimeter depth transducer. But what I find is that in the arm, I usually am using a 1 to 2 reconstitution. So 1.5 cc's of radius or calcium hydroxyapatite to 3 cc's of normal saline. So we're going to take it on over back to the microfocus ultrasound treatment, to the ultherapy device. And you can kind of see right there, if we zoom in, you can see that her dermis here is thinner than that of her chest. It's at about 1.5 millimeters. In Southern California, I see women where it's actually almost just a millimeter. So if you don't dilute your radius, you're going to see some of those white particles. So it is important to really dilute it. So here it is. She's got beautiful skin. Where am I injecting this product? You can see that her fascia is at 6 millimeters, and you can see that her dermis is at 1.5. So I have about 4.5 millimeters of subcutaneous tissue that I'm running my product through.
I have a question. After you inject them, could you use the ultrasound to see where the filler is?
Absolutely.
Can you show us that maybe?
Yeah, we can do that.
That's kind of cool.
It is. So we're going to go ahead and clean her up.
Okay, another question that came through, and I'll answer. Do you think that UVC light would damage the upholstery of your exam chairs? Well, it's a good question about UVC. So we are using UVC lights in all of our rooms. We're doing about 15 minutes in between patients. That's based on the manufacturer's recommendation for the UVC light, which is about 260 nanometers. And it's shown to be effective to destroy bacteria. It destroys the DNA or the RNA of the bacteria and the viruses. So we're using that. And having said that, UVC can be very damaging to humans. So you want to make sure that no one goes in there. So we make sure that we're out of that room while it's being in. Between each patient visit, we are doing UVC lights, and it's been effective for us.
Okay, so we cleaned her with alcohol. Now we did a little bit of Hibiclens, and now I'm going to go in again and do my little dots of Lido with epinephrine. Again, this is an area that has a lot of reticular veins. So you want to be gentle because you don't want to bang them up and bruise them up too much.
You worry about, or what are the watch outs, I should say, in this area?
So again, a lot of reticular veins. Your arteries, like your brachial artery, your those are much deeper, and so they're a non-issue in this
So if
area.
you say just subdermal, you're okay from the arteries.
Exactly.
What happens if you get into a reticular vein?
If you get into a reticular vein, you're probably going to essentially disrupt the lining of that vein, and they're going to have a pretty huge hematoma. Unlikely that you're going to cannulate, you know, that flimsy vein and push product, but theoretically.
Have you seen a thrombophlebitis?
I have not. Have you?
No.
So what am I doing here? So just to kind of show you guys what I do. So this is a 1 to 2, 1.5 cc's of Radiesse to 3 cc's of normal saline, okay? And it's Radiesse plus, so I don't have to worry about adding more lidocaine, okay? On her chest, it was a 1-to-1. On her arm, we're doing a 1-to-2. And so I use a 5 cc lure lock. Some people will use a 10 cc lure lock, but I mix it really, really well. Trying to get some focus for y'all. And then I move forward. So you can see the gray of my cannula, and you see the tip. I'm not jabbing it into unknown territory. I'm lifting it up. I know I'm superficial, and this is called a dermal scraping technique. And it was something that Tatiana Pavic from Germany showed very well with our plastic surgery colleague, an anatomist from France, Trevedic, where they found that the best results when it came to neocollagenesis were when you use this superficial scraping technique, this dermal superficial scrape. So you want to see the gray of the cannula when you're injecting in this area.
So one of the questions we got from Susan is, what size pilot needle are you using?
I'm using, this is a 22 gauge needle, and I'm using an 18.
Using an 18 gauge pilot needle.
Yep.
For a 22 gauge cannula. You do the same thing in the face?
No, she's got thicker skin.
Yeah.
So you saw me struggling when I was using the 21 gauge. And so that's the reason I've switched to an 18. Look how thick her skin is. She doesn't even bleed. So again, you make decisions based on the patient that presents to you. We all use.
So I usually use a 19 gauge routinely with a 22 gauge cannula. I'm getting older, can't see the hole in as much. So I have to use a larger pilot.
So I wiggle my way in, wiggle my way in, and I'm just doing these little strands. Any other questions?
How long do you wait to inject the calcium hydroxyapatite if you have injected PLA in the same area?
Well, they're biostimulators. So just like if I skipped, it's like if I were to do another session of calcium hydroxyapatite, I would wait at least 4 weeks. Truthfully, in the trial that we did on the chest, we did it every 6 weeks. So we did 3 sessions of calcium hydroxyapatite every 6 weeks for 3 sessions. And that got us a 1 grade improvement in chest wrinkles in as early as 3 months after the last treatment.
Wait, so 3 treatments separated by 6 weeks.
Yep.
Getting approximately 1.5 cc's or 3?
Just one syringe.
1 syringe. And you did 3 treatments by 6 weeks. And then after that, you saw an improvement.
3 months later, we already saw a 1-point improvement on a chest wrinkle scale of 5 points.
Can you tell me the name of that scale?
The Fatty Bolton scale.
The Fatty Bolton scale. For those of you who didn't know that, Dr. Fabi created that scale. Okay, so but were patients happy? Was that statistically significant? Was it, or I should say, was it clinically significant to the patients?
Oh yeah, they loved it. They were extremely satisfied. Interestingly, in that trial, we also did 1 treatment arm with a single treatment of all therapy. And it gave us the same results that 3 sessions of dilute calcium hydroxyapatite offered us. So you could do either 3 sessions of Radiesse dilute, or you can do 1 microfocus ultrasound treatment.
Why not double the pleasure and do them both?
And we did. The 3rd treatment arm got both. And so what we found was that patients were happier in the combination treatment arm, but they did not see a statistically significant and greater improvement when you combine them than when you didn't. So patients were more satisfied with the combination, believe it or not, than with either treatment alone.
Okay, we have a question also. I think it was Susan who's asking, do you ever combine it with PRP? And how about for cellulite, PRP plus calcium hydroxyapatite? And what do you think about that?
I haven't seen any studies with PRP, and so I got a little bruise there, so I'm not going to go there. So I have not seen any studies with PRP and cellulite. Have you?
I'm sure there are some. There's studies on PRP and everything.
Yeah, but if we think about, so let's as I always like to break it down. If we think about cellulite, and if we're injecting PRP, what does PRP do? The thought is that it stimulates new collagen production. So if you have true cellulite dimples with an increase in, you have those collagen fibrils that are creating a tethering, I wouldn't want to thicken them up even more. I mean, that's the reason why we have collagenase that's going to enter the market, because it actually disrupts those collagen fibers. So if you have an element of skin laxity, then perhaps you can do PRP. But truthfully, none of the studies have been that impressive with PRP for wrinkles. They've only been impressive for hair. So I'm not impressed with any of the evidence yet.
Okay, we have a question from Anonymous. And Anonymous is asking about how much do you deposit per strand? So I guess.
Yeah, so I'm in, per strand, I'm doing about 0.3 cc's. And so I'm almost done. I have one little strand left to go.
Okay, we have another question here, and
Yep.
This is from Joni. What about skin pen? Or micro needling for that matter?
So another technique that I've used and incorporated, because I feel like with the arms, you need to throw the kitchen sink at it sometimes. I'll sometimes do microneedling. I don't have skin pen, I have dermapen. I pour dilute Belotero on the skin, and I use it as my glider at a 1-to-1. And so then I push it through the skin.
Wait, you say Belotero?
Belotero.
On top of the skin.
On top of the skin.
And then you needle over it.
And then I needle over it. And so I use the HA as my glider. We have to think about what you're pushing into the skin. It drives me crazy as a dermatologist, because many topicals are not intended to be introduced into the dermis. They're intended to go through a stratum corneum. So it's no surprise that we see silicone granulomas when you're pushing that product into the dermis with a microneedling device. But I find that an HA gel that's intended to be injected into the dermis, if you push it into the dermis, it really doesn't make a difference, right? And the nice thing is that you really get it through the entire channel of the skin. I like Belotero because I have not gotten a Tyndall effect, and I think it's a nice gel that integrates nicely with the dermis. But I think that there are many that are in Europe, for those that are following from Brazil or Europe, that are intended to be these boosters, these HA boosters. My favorite outside of the United States is Belotero Revive. It has a little bit of glycerin in it, so it draws in more water and hydrates the skin, because it's not just collagen and elastin that we're losing. We're also losing HA in the skin, which is what contributes to the dewiness of the skin. So that concludes her treatment to the arm. She did really well. You don't really see any of the product. The only thing you see is that little bruise from my injection, my numbing dot, but otherwise, she did really well. So that was a total of 4.5 cc's that was injected of dilute product, a total of 1.5 cc's of undiluted product.
Okay, and what about afterwards? What kind of restrictions do you give her on?
I just tell her to not aggressively massage or go do some compression garment on the area. It's unnecessary. So now we're gonna go to camera 2. You can take it away, Steve, because I'm gonna drop down my patient, and essentially, I'm gonna have her stand so that I can mark her buttocks. So you can.
Okay, so one of the questions we have for you also is, do you worry about nodules in the chest area, especially if you're using PLLA?
So there have been no reports of granuloma formation with calcium hydroxyapatite. It's a biologically inert injectable, and so it does not cause a foreign body granuloma. And there have been no delayed onset granulomas from the treatment, luckily.
Okay, great. So we also have some questions here about the safety. So since I've been doing a lot of research lately on the safety, maybe I can answer some of those.
Yeah.
And one of the questions is, do you wipe down the chairs between each patient? And the answer to that is yes, absolutely. We go through a thorough cleansing process of the room. We're using sodium hypochlorite or a cavicide type treatment to wipe down the room. I have an MA who goes in there. She wipes down the room completely. We've taken away almost everything that was on the shelves that are now gone, and now we put them we put them away behind cabinets. Also be careful, you want to make sure you don't have a lot of cleaning supplies out. They are known to actually leave the office every once in a while. Not sure how that happens, but we do wipe it down. We also then put the UVC light on, which goes by remote. We exit the room, and then before the next patient comes in, the room has been completely and utterly cleaned the best that we can. Question is about aerosolization. So it was originally thought, there was an article that came out in New England Journal of Medicine that said, yes, these products do, COVID, SARS-CoV-2 can be aerosolized, and it can live up to 36 hours on some surfaces like stainless steel and plastic, even on cardboard for 2 days. However, there's less, the CDC just came out this week and said this is an unlikely way in which SARS-CoV causes COVID-19. So unlikely way to cause infection by these types of fomites. So we now think that it's unlikely that you can get it from these fomites. However, it's still important to make sure the room is clean and to always wash your hands. Make sure if you touch something, you don't put it into your hands. There was a study that came out of Wuhan, China, which showed that the product that SARS-CoV-2 can live on mouses for the computer, on your phone, and even on 50% on the soles of the shoes of those doctors that were in the ICU. So the virus can live. Now, whether or not that virus is enough to infect you is a whole different story. No one knows that for sure, but it can live. So for that reason, I think it's important to clean down the room, and then really have to work with your staff to make sure they wash their hands and no one touches their face. I think those are all protective measures for us. Are you ready?
Yeah, we're ready. So
Okay.
we're going to go to camera 1 again. And so you can see with this patient, she is like the ideal patient for microfocus ultrasound combined with a biostimulator. And so she is experiencing what a lot of women experience. And so she has some cellulite dimples. These are true dimples. These are best treated with controlled subcision. And that's something that I would always do first, because what I find is that if you try to lift the butt and you try to fill this volume and you haven't addressed those dimples, people are still going to go to the dimples, and they're not going to be happy with their butt lift or with the volume that you've restored. So I always treat that first with controlled subcision. 1 month after that, I will then invite them back. And in someone like this, with this bit of kind of banana roll and ptosis of the buttock, I will do microfocus ultrasound first. And immediately after, on that same day, if you look at her, she's got some stretch marks. She's got volume loss in her hip dell. These are characteristic traits. I feel like women's butt become more masculine with age. And so what you're really trying to restore is a more feminine appearing buttock. So I'm going to do a little bit of microfocus ultrasound to this area. When I mark for that, I lift the cheek. I draw a line along the gluteal crease. Then I draw a line along the just along the midline. And from that point, I'm going to ask you to pass me the little, I've got the little card right here. I take my little stencil and I'll draw 1 row inferior to that gluteal crease and 1 row superior to that gluteal crease. And I typically end up doing about 4 to 5 columns depending on the size of the buttock. And so David Goldberg did the original trial on ultherapy to the buttock, and he treated patients using this same algorithm, delivered 500 lines with the 4.5 millimeter depth transducer, 500 lines with the 3 millimeter depth transducer, a total of 1,000 lines, and he only did 1 cheek, and he left the other cheek untreated. And he found that the cheek that was treated was significantly lifted in at least 90% of the subjects. I try to repeat that study, but I try to do it with half the number of lines, because I'm like, sometimes it's cost prohibitive to do 1,000 lines per cheek. And what we found was that 66% of patients had improvement. So the number of lines that you deliver matter. It's not that the treatment doesn't work. It's just that you have to deliver the right amount of density of treatment. So it's similar to a CO2. We all know a CO2 laser works. But if you treat at 50% density with the fraxal repair, you're going to get a much better result than if you treat at 10% density. And so that was something that we learned. And so now when I treat with dilute radius, the area that I like to treat is that volume loss along the hip dell. And so you're going to see me do that as well. So I'm going to have you lay down on your abdomen.
So as you're marking this out, once again, I always want to talk about the watch outs. Like, what are the areas that people have to be careful for so that we make sure we don't get into trouble as we're treating the butt?
So with microfocus ultrasound, there's not much that you really have to concern yourself with. You don't have any significant nerves that you're even close to. You're only at 4.5 millimeters deep. When it comes to the butt, though, there are a lot of vessels. And so I've seen people recommend using a Klein pump to infuse these products. That's absolutely crazy. I have reflux back blood multiple times using a 25 gauge needle in the buttock when injecting PLLA, which is suspended in water. So I highly would reconsider trying to make this an efficient treatment and pushing through with a Klein pump your product. This is something that requires the same amount of finesse and consideration as any other area in the body.
So you don't recommend a Klein?
No, absolutely
Okay.
not. No, I use a 22 gauge cannula like you're going to see me use. So in someone like her, I'm going to first, again, I would first do microfocus ultrasound.
And what size transducer do you want?
I'm using the 4.5 millimeter depth transducer. So we're just focusing right now on camera 1. You can see, and so you can see how everything kind of changes when you're laying her down. I would have an assistant retracting and pulling up the butt cheek when I'm treating. We're going to hold that camera just right there. We're not going to move it. And so what am I treating when I'm treating with the 4.5 millimeter depth transducer? And so in someone like her, her fascia is actually a little deeper than, you know, maybe someone of a BMI of 21. And so that's something to be thoughtful of, because maybe she's not going to get as great of a result, right? So we're going to go,
can't reach the,
because you can't reach the target. So that's why it's really nice to do ultrasound visualization, because then you can be more realistic with, you know, your patients. And so if we go to the microfocus ultrasound screen, we're going to swivel right on over.
A little bit below you there.
You can kind of see that her fascia, you know, in her lower thigh is there. It's almost at 4.5 millimeters. Yeah. We're going to zoom in a little bit more. We're zooming in, and you can see that fascia, and we're going to bring it up a little bit so we can actually see the fascia right there. And you can see that it's at the green line. So that's why visualization is so important, right? But if you move up, the reason I treat in this area, and this is where David Goldberg treated, is because this is where you have the greatest density of those ligaments that hold the butt up. If you start treating higher on the butt, you've got a lot more fat. So you're never going to get to that superficial fascial system. Okay? All right. So there I would treat with the 4.5, and on someone like her, I would essentially deliver about 50 lines with the 4.5. We're going to come back to the treatment to the patient. I would treat 50 with the 4.5 and 50 lines with the 3 millimeter depth transducer. And I would do that in every single square. So essentially it's 100 lines per square for a total of 800 lines, if that makes sense.
Okay, so we got a question from Susan asking what brand cannula you prefer and why.
Honestly, I've used what I've gotten used to. I don't got a lot of science to support this one. I've gotten used to Dermisculpt, and so I use the 2 millimeter Cleanse with gauze love. Thank you.
I like soft fill, and I use a 22 gauge, 70 and 50 millimeter for that. We also got a question from Julie Woodward, the famous friend, oculoplastic surgeon from down south from Duke. She asked about hypochlorous acid in your eyes, and she is an oculoplastic surgeon. So Julie knows that it's safe to use in the eyes, even though it's not FDA approved for that in the US. She does put it in the eyes, so I do too. And she asked, what about putting in the nostril? I put 1 cc of the betadine mix I showed you earlier into the nose. but I also do hypochlorous acid into my nose myself. That's just what I do. But once again, that's not FDA approved for that here in the US, but it's.
Guys, we put this on open wounds. I've been using hypochlorous acid on people that get laser resurfacing, fully ablative laser resurfacing that have no epidermis, immediately on the table after I laser resurface their entire face. And we do it as our post resurfacing protocol every 2 hours after a vinegar soak for the last 2.5 years. Never had any problems. In fact, we've actually seen a reduction in colonization by bacteria as a result.
There's actually an article on this that just came out.
So it's nothing, hypochlorous acid is nothing new. I think, in fact, it's actually helping us.
In Australia, just today, I saw a press release tested against SARS-CoV-2 and says that in Australia, not in the US, and that they're allowing it to be noted that it works against SARS-CoV-2. So
we're coming back to camera one. And so we're kind of at like the last 15 minutes of the presentation. For those who have any other pressing questions, definitely this is the time to please ask us.
So once again, we had a question that was, Ingrid wants to know specifically about your dilution in the arm, and it was 1 to 1. Is that
1
correct?
to 2 in the arm, 1 to 1 on the chest.
Okay, 1 to 2 in the arm, 1 to 1 in the chest.
And if you ever have questions on dilution, you can definitely check out our consensus recommendations published by first author Kate Goldie in November of 2018 in Dermatologic Surgery, where 17 of us from all over the world got together to come up with consensus recommendations of what dilutions you should use depending on where you are.
Okay, and we got a lot of questions about the face and dilutions and which products we use, Belotero, Bobello, calcium hydroxyapatite. So we do want to address your questions about the face, but that's going to come up in the next episode. So please hold those until we come back to you on that, because that's a whole nother way of treating the person. And there you really have to be strict with your post-COVID protocols to make sure that everything is safe. So we will get to that, but we use all these products and more in the face. All right, we have another question. Do you massage afterwards?
I do not massage afterward. I really only massage with PLLA. I have not gotten into the habit of massaging with calcium hydroxyapatite.
Can you tell me a little bit about pricing? I know we haven't touched on that at all, and maybe that's a little gauche to talk about that, but I think people always want to know, like, you know, I'm impressed to see you're not using a lot of filler. So
No.
it seems like it's affordable.
Oh, it's super affordable. I mean, you know, one syringe in our practice of this is about $800.
Okay, so
And
if you're
so
doing
if I just did her arm, I would have ended up using 3 syringes. And I would probably tell her she's going to need 2 to 3 treatments spaced at least 6 weeks apart. If she wants to be more patient, she could even space them up to 3 months apart.
Okay, so 3 syringes plus microfocus ultrasound?
Depends on the level of laxity. In her arms, I would have only done calcium hydroxyapatite. In her butt, if she really wants to lift her butt up, in addition to really improving the quality of skin in this hip dell, she's going to need both. In her chest, it's either going to be one or the other, because she does not have severe wrinkles in the chest.
So that's 3 syringes, 3 different times, so 9 syringes total over a like 18-week period of time.
If we treat all these areas?
Yeah.
Yeah, if we treat all these areas.
So have you noticed, now that you're back open in the office, are people still coming in, or are they afraid to spend money right now, or how's that? What have you noticed?
I got to tell you that in San Diego, people have been really ecstatic to be able to come in and get the treatments. During this time, I feel like maybe people actually had the time to think about really what bothers them more. And so as a result, people are really investing into themselves. And maybe I've actually seen people investing more into themselves, which includes these aesthetic treatments, than investing in like a Gucci purse or a Chanel pair of shoes, you know?
Or travel. And I've noticed also that I have a lot of my patients who are now in town and they're wanting treatment. So I've been back in the office for a week now, and I'm incredibly impressed with how busy we've been, knock on wood, with people really coming in. I wasn't certain that was going to happen.
Yeah, I mean, this to me is, you know, aesthetic treatments are more than vanity. I mean, I think that a lot of people feel better as a result of them. And so it really contributes to like
Absolutely.
what we're seeing more and more is people investing in their overall wellness. So,
and I know I've published a lot of papers on the self-esteem impact of aesthetic treatments. So I'm a big advocate for the improvement that you get in self-esteem from these treatments.
And we know that, especially when we talk about these biostimulators, you know, more than ever, these are procedures that are really restoring our own dermis. They're really like you saw in that study by Yana, they're causing new fibroblast proliferation. So you're truly anti-aging. So it's more than just augmenting or reshaping something. You're just really, you know, anti-aging the skin. You're restoring it back to its more youthful characteristics. So especially today when people are spending all this money on oral collagen, which does nothing but stress the kidneys, you know, this is something that actually has science to support its claim and truly stimulates new collagen production. And this is an area where you wouldn't want to necessarily laser resurface the skin, right? You're really limited with what kind of modalities and devices you can do in this area.
Okay, while you're injecting there, any major arteries to worry about?
Not when you're this superficial.
Or that lateral?
Or yeah, unless you're like sticking it into the muscle. We're not in gluteus, you know, in the gluteus medius muscle. We're not in the gluteus minimus muscle. Those muscles have much larger arteries than does the face.
So really important.
So very important to be superficial. Like you see me, like I am doing everything that I can so that I'm comfortable and that my cannula is going parallel. I'm not just jabbing it in and going into the abyss. So you need to have full control of where the tip of your cannula is.
And when do you see the results from this treatment?
You start to see, patients start to see it in as early as 6 weeks. So in the trial that we did on the chest, because that's all that I can really speak to, you know, we saw patients already having a significant improvement in chest wrinkles in as early as 1 treatment 6 weeks later.
And the question that we always get from every single patient is, how long does it last?
Yeah, so in the trial, that significant level of improvement only continued to get better up to a year after the first treatment, 9 months after the last treatment. And it was not decreasing, it was actually getting better. So I would actually say, we know that once you stimulate new collagen lasts up to 15 years. The problem is that the collagen that you have is breaking down, you know, and so it's you're chasing your tail with it. And depending on what age you are, if your fibroblasts are senescent at 40, you have to keep doing more things to trick it to create more. So I typically tell my patients, do 1 treatment every year thereafter to just maintain your result, but you don't got to do all 3 treatments every single year.
So continuous improvement up through 6 to 9 months you saw in your trials.
Yeah.
Do you recommend any collagen nutritional supplements that may help collagen? You know, sometimes people talk about vitamin C or other things like that.
Oral collagen only stress the kidneys. There's no studies to support that it stimulates any collagen at the level of the dermis. So I think we're almost up with time.
No, but we have an important question here. Dr. Fabi, you look so beautiful. What is it that you actually do to continue to look so beautiful?
I get a lot of sleep when someone isn't stressing me out.
Okay. We got another question. When is episode 2 going to happen? Stay tuned. We'll hopefully be announcing that really soon.
We just want to thank MERS North America for putting a grant to sponsor this program so that we can educate and keep up to date and keep you all up to date. With
and MER, Medical Education Resources, also for helping us with the CME. So you will all get CME. Make sure you fill out the evaluations afterwards. You have 30 days. If you don't fill it out in 30 days, it may be an issue. We are going to hopefully post this also. So for those of you who want to come back to this, it should be online. So stay tuned. Within another week, we'll have this online on YouTube and you can go access it at any time. And there may be ability to get CME credits even afterwards. Also, thank you, Avenue Live. They're the ones that have helped us logistically with put this together. They also work with Bryn Mawr Communications, the producers of Modern Aesthetics Magazine. So they've been helpful to make this come to fruition. And we did this all within a week. So it's great that everyone was helpful. And to our production team here, Allison, thank you so much. She was working around the clock. And to Dr. Ben Coughlin, who's been here. And then to Salika, who's been here working. She's our lovely assistant today, who's been helping out also.
So thank you to all who attended today. Right after this, you are going to see a link to where you can click to do your post-survey test, as well as to redeem your CME credits. And make sure to go on my Instagram at sabrina.fabi, F-A-B-I, in 6 minutes, where we're going to be doing an after party to answer any residual questions that you may have, or anything really that you want to ask both myself and Steve and Diane.
And it's BYOB for that event.
Thank you, guys. Bye.
Okay, we'll see you soon.